Good morning. Yeah, I just wanted to make sure that people understand kind of what's going on nationally and also on the state level. There's a lot of talk, you read the Boston Globe, you read the Herald, about issues with primary care crisis in the state, and that the state has provided insurance coverage. And I get asked a lot of questions when I go to national meetings about Massachusetts, as they know about Massachusetts, and say, what's going on in Massachusetts? So, you know, I get asked a lot of questions about healthcare reform, and I'm very positive, because I remember when we would be trying to take care of patients that had no health insurance, and it's just so much nicer as a clinician to you know, not have that be a barrier. But the problem is, as you all know, in the state right now, is we have a primary care access crisis, and the Massachusetts Medical Society does a workforce study every single summer, and they just came out with their last one. And it's been a downward trend in terms of need for primary care physicians. There's only one specialty that's listed by the Mass Medical Society as being in crisis mode in terms of the need versus what we have available to patients, and that's family medicine. So you would think that we're producing family physicians in Massachusetts, that, you know, things would be looking very good in terms of support, but as Bob just suggested, there's been just a continual ratcheting down of federal support for graduate medical education, and that's because of the Medicare issues and the funding issues for Medicare. So, you know, we've seen it in every residency program in the country has seen this. And the other problem is that there's a disconnect between what the public needs and how we train physicians in this country and how we pay for those physicians. The system that we're using right now is a 1965 model. So the last time this was really renovated was when LBJ was the president. And it was in a world where most of the time we trained physicians in hospitals. And so the funding is still very much towards hospitals. And so even our own funding doesn't come to us, it goes to Lawrence General Hospital because of this anachronistic system. So there's been a lot of articles in New England Journal of Medicine, et cetera, about there needs to be reform of graduate medical education, payment reform. And so there's a lot of talk, and there's actually in the federal legislation, there was provisions about teaching health centers and having funding coming to community health centers. But, you know, we're in a regulatory phase right now where people are trying to interpret the language of Congress, and so my concern and Bob's concern and all of our concerns is that that language will be interpreted so that the money gets to where I think it was intended in the spirit of the law, which is adequate funding come to community health centers. So if you look at the national picture, historically in Massachusetts, if you look at you know, the number of physicians in Massachusetts, we actually have the highest per capita physician to population ratio in the United States. We have more doctors than anywhere else in the country per capita, but we have the wrong kind of doctors. We have mega subspecialists. We have, you know, these big teaching health centers in Boston, and that's, a lot of people think of healthcare as the Boston teaching hospitals and Longwood Avenue and Mass General, and not recognizing that, you know, most of that healthcare actually happens in places like community health centers and primary care entities. So if you look at where medical students are trained, they're trained in tertiary medical centers, and there's actually a bias in tertiary medical centers against primary care. Because most of the people in tertiary medical centers are subspecialists. So that in addition to the fact that we have medical students now in the state graduating with over $200,000 of debt, and they look at the income disparities and they say, you know, I'm not sure, you know, it's a smart move to go to primary care. So we've basically seen that the system is perfectly designed for the results it's getting, which is a steady decrease in the number of medical students in the United States choosing family medicine. And traditionally, in Massachusetts, primary care has been provided by general internists and general pediatricians. The problem is that the general internists, the internal medicine programs in Massachusetts are not producing general internists. They're producing gastroenterologists and cardiologists and subspecialists. The general pediatric programs are not producing general pediatricians anymore either. So there was a study done in the Journal of the American Medical Association 2008. They asked people going into internal medicine residency programs, do you envision yourself going into primary care? And these are people going into internal medicine residencies, and the number was 2% are going to primary care than they intended. Whereas on the other hand, family medicine is really becoming the primary care specialty. It's where this country is going to get its primary care workforce. And the issues, as I was talking about, was that there's a funding disconnect because most primary care programs are in smaller community hospitals, or in our case, a community health center, and we don't have the clinical revenues to offset these funding cuts that Medicare's been inflicting on us. So we don't have, so Mass General can absorb the state cuts as far as the GME, but a community health center like us, that's 25% of our residency budget. So we've just been through, just so people know, we've been through a very painful budget process where we had to cut $300,000 from the residency budget, and the residency budget isn't that large, and eliminating some good things because of just the need to try to balance our budget and absorb these cuts. If you look at clinical measures, what we're trying to do is train family physicians in the real world and in our community health center. And so it's not an ivory tower kind of experience where we have residents who are downstairs taking care of patients. They have a panel of patients who consider them their family doctors. So there's some costs attached to that because it's not a very efficient process. An intern that just come in, and we just had 10 interns come in, cannot see 4 patients an hour like an experienced clinician. So there's a cost attached to that because of we still have to pay for staffing, overhead, et cetera. But if you look at our clinical measures, just like on the subspecialty side where academic centers tend to do better in terms of outcomes, if you look at things like patients seen in the first trimester, these are pregnant women, our outcomes are better than both the Massachusetts average and the national average. If you look at things like HIV testing, where again above the national average and the Massachusetts average. If you look at mammograms, and we have, as you probably know, a really wonderful program downstairs, and we have a screening mammography unit here, which is very nice for patient convenience. So we're way above both the Massachusetts average and the national average.